I'm going to start sharing. So here we go. Let's do that. I hope you can see my screen.
Yes, we can see it, Dr. Ken.
Thank you. Let me just dismiss everything and get going. So firstly, I would very much like to thank everybody for allowing me to speak. It's always a little difficult, you know, as a pediatric ophthalmologist to talk to a general audience, but what I'd like to sort of frame is that I've been coming to the UAE since 1999. Initially, when I was at Great Ormond Street, I've worked at Abu Dhabi, I've worked in Sharjah as a visiting doctor from Great Ormond Street, and then continued that work here at the University of Pittsburgh Medical Center, Children's Hospital of Pittsburgh. These are my disclosures, none of them really relevant to what I'm going to talk about today, but I thought what would be a good idea is to really talk to you about what I mean by a paradigm shift. You know, pediatric ophthalmology and strabismus for a very long time was considered to be strabismus and, you know, runny eyes, blocked tear ducts. But I want to show you that there's been a real paradigm shift in both the diagnosis and the interventions we can do now as we've become more and more super specialized within this field of pediatric ophthalmology. And the conditions that I commonly see in the Middle East are common ocular problems in well children, common ocular problems in systemically unwell children, rare ocular problems in otherwise well children, and rare ocular associations or problems related to systemic illness. Now, clearly, in half an hour, I'm not going to be able to give you a comprehensive view, but what I thought we would do is perhaps pick on some of these conditions and show you how the intervention and the diagnosis has changed. I always do this for my pediatric colleagues. Just a quick test. I hope all of you are labeling what these different levels of the eye parts are. There's the iris, which is the colored part of the eye, the pupil, which is the black hole in the middle of the eye, or the middle of the iris, the lens, and then you've got the retina, choroid, and then the optic nerve. And all of this will become relevant as we go forward. The retinal photoreceptors are really important. I see a lot of retinal dystrophies from your region of the world. Rods, they help you look in dim light and peripheral vision. Cones help you look in bright light, central vision, and color vision. Just keep that in mind when we talk about retinal dystrophies. Look, one of the commonest problems that you see in well children is myopia. And the reason why I want to talk to you about this is that myopia is due to the fact that the eyeball is longer than it should be. Sometimes the cornea is too curved, but usually it's because it's longer than it should be, and that's the picture at the bottom. According to the National Institute of Health in the United States, 33% of all Americans are nearsighted or myopic, and those numbers are higher in the Far East and also in the Middle East. And the question is why is there an increase in incidence of this condition? And it's thought to be due to decreased daylight exposure, increased near-work exposure, and hyperopic peripheral retinal blur. Now, if you don't understand what that last thing means, I'm going to explain it to you. Essentially, everything that my mother told me and my grandmother told me, and I thought that they were wrong, is true. We know now, and this is a superb paper, showing that there's an association between time spent outdoors and myopia in children. In fact, there is a recommendation that to prevent the progressive myopia of childhood, you know, this is when I was 11, I was diagnosed as being nearsighted. They gave me glasses. Then every 6 months, I would become more and more nearsighted. And I bet there are many of you in the audience who recognize that story. Well, it turns out that if you have 2 hours daylight exposure, not necessarily outside, you could be sitting inside with the sun coming at you, that protects you against myopia. Now, obviously, there's a genetic influence, but the environmental protection is important. Now, you see these glasses that I'm wearing? They're myopic glasses, so they're concave. Well, it turns out that when you put these on, it makes your central vision good, but your peripheral vision goes into what we call a hyperopic blur. You see that middle ray diagram? What's happening is that the periphery of the retina thinks that it's blurred, and it is because of the way these concave lenses actually bend light. It turns out that it's your peripheral retina that drives myopia between the ages of 8 and 16. So the eye tries to grow to try and catch the light. The longer it grows, the more myopic you become. So now we're making lenses that will stop that happening, and that's the picture that you see on the right. So there are newer specially designed lenses that reduce peripheral hyperopic blur. But what I want you to think about is all the times that my mother used to say, play outside, your eyes will be strong. She was right. When she used to tell me not to wear glasses all the time, my eyes would become weak. She was right. So remember that the take-home message is always listen to your mother. Here's the important thing. We now have a control mechanism of drops called atropine 0.01%. And this study was a landmark study because it showed that you could control myopic progression in a significant proportion of children who were getting myopia. Now, we're talking about myopia that starts around 6 to 9 years, is progressive until the age of 16 to 17, not the myopia that is due to a pathological reason like a retinal dystrophy or glaucoma or anything like that. So this is an important thing that you as pediatricians should know, that there is a way of controlling myopia. And you might say, so why is it important? The longer your eyeball, the greater the risk as you get older of macular degeneration, glaucoma, retinal detachment. So if we stop the eyeballs getting bigger, which is what all of these efforts can do, we are preventing problems in the future. So it's an important thing to know. And at Children's Hospital of Pittsburgh, we have a myopia treatment center. By all means, go on our website and have a look and see what we've said. And if you want something that gives you an overall statement, if you go to wspos.org, which is a charity, they have a myopia consensus statement that's used by many people all over the world to help explain to parents and pediatricians what's available. Strabismus is when the eyes are not aligned, and this is very common. What I want to show you is that sometimes we get strabismus where the strabismus has been operated on and it comes back. Reoperations can be difficult. Here's another child who needed a reoperation. This technology that I'm showing you is called ocular coherence tomography, and we have it inbuilt in a microscope. It is available around the world, but what you can do is you can identify the muscle before you go looking for it so that you reduce the amount of scarring. So here's an intervention that has changed because we have this technology to do that. So again, if you have a patient who has strabismus and has had reoperations, the reoperations are made more predictable by being able to work out where the muscle is. There are some children with developmental delay in whom, rather than do actual surgery, we give botulinum toxin injection. And the reason is that as they grow, the position of the eye changes. And because they don't have normal fusion of images, because of their developmental delay or their cerebral palsy that they may have, you can reduce the amount of surgery by waiting till they're older, but still allow them to interact with other children by having their eyes in a reasonable position. So again, you should be aware that this is an option. So let's talk about conditions that are commonly seen in the Middle East, but perhaps are more due to rare conditions. I want to introduce Professor Alki Liassis, a colleague of mine who runs the Electrophysiology lab here at Children's Hospital of Pittsburgh. He and I work together at Great Ormond Street. All of these children, you see these babies, they are having electroretinograms done without being put to sleep. And this is important to understand. We also do visual evoked potentials. Visual evoked potentials are very important in children who have craniosynostosis or who have raised intracranial pressure and you're worried about a shunt blockage and you can't see the optic nerves are swollen or not, because often they're not and the pressure can be raised. And we use VEPs to monitor these children because we can see a abnormality in the visual pathway. Here's a child who's a baby having an ERG, and we can, through the method that we use, say if the retina is normal or not. And this is an important consideration. I see many children from your region that have congenital corneal opacity. Before you think about corneal transplants in these children, you need to know that the retina and the optic nerve are functioning. And we use ERGs and VEPs to determine that. It's important that you have large normative data if you are going to use skin electrodes to do the VEP and the ERG. It's very important. And we are lucky enough that we have a large normative data bank to be able to assess these kids. Skin ERGs are able to assess retinal responses. Here's a child who had been treated for unilateral retinoblastoma. There was a concern that the retina wasn't working because of the chemotherapy that had been used. And in fact, we found that it wasn't. So we didn't have to try and patch the child because patching wasn't going to improve the vision because the retina was damaged. Now, of course, by giving the chemotherapy, which was the intravitreal chemotherapy that's into the vitreous of the eye, you save the eye. And so they're, expecting some damage to the retina is reasonable as a side effect of saving the eye. We can also do skin ERGs to record pattern ERGs and pattern VEP. So a VEP is a visual evoked potential. You see what's happening at the brain. A pattern ERG tells me what's happening at the macula to assess a 3-month-old with glioma in the right optic nerve. And why is that important? Because it helps monitor or help make decisions about how you're going to treat this child. A 3-month-old is not going to give you a robust visual acuity response. So this is a child who actually came from the UAE to me. If you see on the picture on your left, she has the classical picture of lipemia retinalis. This was due to lipoprotein lipase deficiency, giving a huge amount of hyperlipidemia. But after dietary management, you can see that the retina and the nerve reversed and improved. And in fact, we showed this, that the electroretinogram improved. So improved visual function with dietary intervention in a child with lipemia retinalis. So again, what I'm trying to give you a gestalt about is the diagnoses and the diagnostic capabilities we have nowadays in pediatric ophthalmology, and then the interventions and how we monitor those interventions. I see a lot of congenital glaucoma from your region of the world. The classical triad is tearing, ophthalmos, which is a large eye with splits in the cornea, which are called Harbstrie, and cloudy cornea. So here's a child, won't open his eyes, it's very painful, and you can see that the child at the bottom has one eye that's bigger than the other because of the glaucoma. Again, this is a child who came to me from the UAE, and I've done a trabeculectomy. This is right at the end of the procedure. The cornea is cloudy, but with the control of the pressure, the cornea will clear. Often you're left with Harbstrie. Now these Harbstrie, they're breaks in the visual axis, and it's like looking through frosted glass. So what can we do? I'm going to show you towards the end of the talk that we can now do partial transplants. We can take the inner layer of the cornea off and replace it with a donor inner layer so that the integrity of the eye remains intact, but you can visually rehabilitate these children. So pediatric ophthalmology has gone from just patch and hope that you can improve the vision and give glasses to replacing diseased tissue and giving an absolutely clear visual axis. And I'll show you a picture of a child in whom that's been done. That is called an endothelial keratoplasty. Dermoids, corneal dermoids are very common, and I'm sure you know that they occur in Goldenhar syndrome. But one of the conditions that they occur in also is this. This is courtesy of Andrea Molinari. This is a child that has cutis aplasia and these dermoids both on the bulbar conjunctiva and the cornea. And this child actually has ocular ectodermal syndrome. And here's another child, again, with a very particular type of dermoid that's very flat, and it affects the cornea. It also affects their extraocular muscles because they don't have normal extraocular muscles. And they can have a high incidence of what we call choroidal osteoma. You can see the choroidal osteoma here, which is the high reflectivity in the back of the eye. This is a child who came to me from Abu Dhabi. He had this condition. This is linear sebaceous nevus syndrome. And the VEP and the ERG told us that he could see something. They were within normal responses to bright flash of light. But this is what his eye looked like. I did corneal transplants. His extraocular muscles were not intact. But once we gave him that window to see, this boy innately would move his fingers, move his lids down to be able to see with. So if you give a child the opportunity to see, they will use it. These three conditions, linear sebaceous nevus syndrome, encephalocraniocutaneous lipomatosis, and oculoectodermal syndrome, are part of the same spectrum of disease. My whole point of showing you this is that I do see rare ocular conditions in rare ocular systemic diseases, and I see them in a higher rate in certain parts of the world, and the Middle East is one of those parts of the world that I see that in. One of the things that I think has really come up is ocular genetics. You know, we have dedicated genetic counselors. I do an ocular genetics clinic. And what I want to share with you is, you know, how amazing this time is for pediatric ophthalmology and ocular genetics. I want to share with you a case that we called personalized pediatric ophthalmology. This is a child referred to us by our pediatric colleagues. He was a 3-year-old male with atypical mitochondrial mutation that had been described in Leber's hereditary optic neuropathy or Leber's hereditary optic neuropathy plus, and had also been described as causing Lee's syndrome. But he had features of opsoclonus myoclonus ataxia, which had a partial response to immunotherapy. So it was decided that a whole exome sequence would be done. And on that whole exome sequence, he was found incidentally to have a highly penetrant retinoblastoma gene mutation. So imagine now, I have a 3-year-old boy who has all these other neurological problems, and the whole exome sequence reveals that he may have an RB1 mutation. An RB1 mutation that's highly penetrant means that there's a high chance that this child will get a retinoblastoma. So what we did was we did an exam under anesthesia. Now, this was his initial pictures that we took in clinic. But when you're 3, if you're going to get retinoblastoma, you get it in the periphery. And when we put him to sleep, I hope you can see this white circular mass at the very anterior part of the eye. You could not see this awake. And the point is this, that because we saw it, we treated it with cryotherapy and laser, and it's gone. If we had not done this, this is the type of child who would have presented with an eye full of retinoblastoma because it would not have been seen. So here we have, into 2020, the situation where a whole exome sequence, for one reason, picks up an incidental disease which we can actually now prevent from destroying this child's vision. Okay, I mean, I think that this is an amazing age for pediatric ophthalmology, and I want to share with you now some surgical innovations. The cornea is made of several layers, and it's only 0.5 millimeters thick. Traditionally, when you do a corneal transplant, you do a full thickness transplant, you take all the layers away. But we can now do a deep anterior lamellar keratoplasty, which means we leave the inner layer and we just take the epithelium and the stroma. Or we can do the endothelial keratoplasty, which is where we take these two layers away, descemes and the endothelium, and just replace those. This has completely changed the survival of grafts in children. I see a lot of children with congenital corneal opacities. I see a lot from the Middle East, a lot from your region of the world, especially the UAE. Now, the incidence is supposed to be 1 in 26,000 live births in Europe, but it is higher in the Middle East. Here is a child who came to me. This is, they're two different children, actually. This is the opacity that in the top right. This is an opacity in the bottom right. And this is after we had done corneal transplants, and you can see the clarity. It's true that it's a difficult procedure. It's true that it's high maintenance afterwards, but it's true that you can give these children not only central vision, but often these grafts will begin to fail after 4 or 5 years, but you've given the child developmental vision. You change the development of a child under the age of 8, especially an infant, by doing corneal transplants. The other thing I have had a lot of patients from your region and the world from is patients with mucopolysaccharidosis. This is a paper I wrote with my group. I think it was 2010 that we published it. Here's a child with Maroteaux-Lamy syndrome, and instead of doing a full thickness corneal transplant, what we can do is a partial transplant. And this image here shows you how I separate the posterior surface of the cornea, take the diseased cornea away, and I can then put on a donor. Why is that important? Some of these children have developmental delay, and they will sort of knock their eyes. If you have a partial transplant, even if they knock their eye, the partial transplant may come off, but the integrity of the eyeball, this layer here, remains, so they don't lose their eye. Endothelial keratoplasty is what I want to sort of really finish with, and this has really changed things. This is a child who had bad glaucoma. The glaucoma was controlled, but his cornea had decompensated. He had lots of Harb's tree. So this is in real time. What I'm showing you is we did an endothelial keratoplasty. And what you'll see on the OCT is me bringing into focus the fact that we had pulled in the graft with a suture. And I'm just going to correct the optical correction here. I think you can see that. There it is. There is the graft. And what we did next was, because we have the OCT and because we can clear these children's corneas, I injected air, and just with air, this graft attaches. So the inner layer of the diseased cornea has been removed. A new graft has been put in. Here it is, and I'm inflating the eye with air. And once I do that, the graft comes up. This child had perception of light vision. He was 6 years old. 6 weeks later, his cornea is crystal clear. The graft is still intact with 3 years down the line, and he has 2100 vision. You change, absolutely change what this child's life is going to be like. So in the last couple of minutes, gene therapy is here. FDA approves the first novel gene therapy to treat patients with a rare form of inherited vision loss. It's RPE65, you Leber's congenital amaurosis. UPMC Children's is being processed as a site for this gene therapy. There are other gene therapies that are being done at a clinical trial level, but you need to do deep phenotyping. This child has the molar tooth sign. Here it is with ocular motor apraxia and retinal dystrophy. He has Joubert syndrome, and there are therapies and trials going for that. We can do autofluorescence to show that this is abnormal, that there is a retinal dystrophy here. And this retinal dystrophy was senior Loken syndrome with kidney problems. This is nephronothiasis. So in summary, I could have talked just about gene therapy. We are on the precipice of the most exciting time for children. But pediatric ophthalmology has changed. It's a new paradigm shift in what's possible. The diagnostic capabilities and the therapeutic capabilities have changed. And if you'd like to discuss any cases with me, this is my email address, that's my Twitter handle, and it's been a pleasure talking to you about pediatric ophthalmology, a new paradigm shift.
Excellent. Professor Nischal, this is indeed eye-opening to most of us, who practice pediatrics, but not specifically in ophthalmology, really. It seems to have changed quite a lot since the time we were in medical school, really. I think providing you email address might actually be the answer to one of the questions, as how do the people, contact you and refer patients to your center?
Yep, you've got my email address.
Yeah, indeed. So I'll just, before I run some of the questions, I think I may just want to ask you to perhaps enlighten us about the role of school in screening for eyesight problem, because children sometimes live in families, you may not really see the changes in them quite clearly, but for somebody else, like a teacher, they may not be much easier on them, really.
I'm really glad you asked that question. You can imagine one of the issues whenever I'm asked to talk to a general pediatric doctors who are much more knowledgeable than I am about children as a whole is trying to figure out what the balance is. Now, one of the things I want to say is that school vision screening is mandated in many countries, but I don't know if it is in the UAE. Mm-hmm. I think at school, what teachers often do is they say, so-and-so is finding it difficult to see the whiteboard, or they seem to be having difficulty reading, and parents will then take them to have their eyes checked. One of the things that I find really helpful that happens in the United States is that the pediatricians have a autorefractor, which is a machine that takes a picture and tells you whether there's a refractive error in the child's eye, but also tells you if the red reflex is missing. I think this is one of the great advancements, because you can also get photo screeners on smartphones now. And it's a very quick and easy way for the pediatrician to pick up when they do vision screening, whether there's a problem. But you're right, teachers often will send messages to parents about the fact that the child either is adopting an abnormal head posture, is squinting, or that they're having difficulty reading. Reading difficulty is really interesting in the age group between 7 and 12, because there's a subgroup of children who have this issue where the facility of accommodation, the ability to look in the distance and then look at near, which we take for granted when we're young, disappears momentarily, and it'll disappear for 6 months, and their writing gets bigger, they jump lines, they mix up letters, and sometimes they're labeled as dyslexic, and sometimes they are, but often all they need is their accommodation to be tested by either a pediatric ophthalmologist or an optometrist, and they get temporary reading glasses that fixes that. So I'm really glad you asked that question.
Yeah, indeed, and I think there is an important question which I basically try to select out of quite a few others, is actually the role of gadgets, looking yes. at, yes.
So, I did a webinar about digital eye strain. There is absolutely no doubt that with the pandemic and the lockdown, children have reverted, or rather converted to digital school. And the more time you spend at this distance looking at a screen, 3 things happen. Your accommodation is always switched on, which is a problem because you get an eye strain. The second thing is, when you're looking at a screen, you don't blink as often, so you get dry eye. And the dry eye makes things blurry. Imagine you're driving in Dubai on a hot summer's day, and your windscreen on your car is dry, and you don't have any washer fluid to clean it. Well, when you switch on your windshield wipers, it makes everything blurred and smudgy. Well, that's exactly what happens. The windshield wipers are our lids. The cornea is the windshield or the windscreen. And when they dry and you blink, everything becomes blurred. So this is what we say. There's the 20-20-20 rule. After 20 minutes on a screen or on a gadget, you should get a child to look away for 20 seconds at something 20 feet away, outside the window, to break that constant accommodation. There's no evidence that blue light filters help at all, and there's no evidence that blue light is damaging that comes off digital screens to the eyes. So I hope that helps. It's also a good idea to have a humidifier or a bowl of water near the child when they're doing, 3 or 4 hours work of schoolwork on a screen.
Interesting, really. I think the discussion can go on and on endlessly, really, but fortunately we're limited for time. But reassuringly, one of the audience said that, Jacob says that the eyesight screening is actually mandatory in Dubai Health Authority. So Perfect. Kids do get a lot of screening at different stages.